Hello, and welcome to a discussion on pathology of the upper gastrointestinal system. This PowerPoint will start with slide number 7, and we're going to start by talking about common symptoms of upper GI pathology. So, as you notice, I've listed some common symptoms: loss of appetite. Remember, the medical term for loss of appetite is anorexia. Nausea and vomiting, a change in bowel habits, an elevated temp, heartburn, indigestion, and dysphagia. And remember, dysphagia means difficulty swallowing. Now, a new term to us is called malaise. And malaise is a general feeling of discomfort. Just something doesn't feel right, you feel out of sorts, you just know something's off. And this feeling of malaise is generally the first indication of an infection or disease process. All right, so let's talk about eating disorders. There's a couple disorders that I want to discuss, and I want to start by saying, remember, eating disorders are often not caused by a physical problem, they're psychological in nature, and oftentimes we call these psychogenic. So again, having a psychological origin rather than a physical one. Anorexia nervosa is one we've talked about before, and this is the condition where patients will starve themselves. It's this unnatural fear of gaining weight or becoming fat. So they will avoid food, and as a result, they'll have weight loss. You can lose your hair, you can become anemic, and this is all because you don't have the nutrients that you need because you're not ingesting the right foods or healthy foods. So we can do an upper GI to rule out other causes, but again, generally this is psychological in nature. Now another one is bulimia. And like anorexia nervosa, bulimia is psychogenic in nature. And again, it's this morbid fear of gaining weight or becoming fat. So what patients do is they'll eat a lot, they'll binge, they'll overeat, and then they'll purge or throw it up to get rid of it. They may abuse laxatives to help them go to the bathroom. And again, we know that laxatives or cathartics will increase peristalsis and help empty out our intestines faster. So again, we're not absorbing any nutrients. Now, generally, there's no diagnostic testing for bulimia. It's, again, psychogenic in nature. All right, let's talk about esophageal reflux. All right, so esophageal reflux occurs when the lower sphincter in the esophagus doesn't work properly and contents from the stomach reflux into the esophagus. And what happens, the problem is, remember, the stomach is really acidic. There's a lot of acids in the stomach to aid in digestion. So all of that acid will irritate the lining of the esophagus. Now, most of the time patients say reflux, they report it as heartburn, but it's actually reflux. Now, specific causes for reflux haven't been confirmed, but physicians think that cigarette smoking, excessive aspirin intake, alcohol, and caffeine can all contribute to the incidence of reflux. All right, so the lower sphincter isn't working right and gastric juices go backwards. The next term we need to know is achalasia. Now, achalasia is also known as cardiospasm, and it is a reduced peristalsis in the distal 2/3 of the esophagus. What happens is the esophagogastric sphincter, okay, so the sphincter from the esophagus to the stomach doesn't relax during swallowing. And therefore you have reduced peristalsis distally, which you're seeing here. And what happens is the esophagus actually becomes dilated with food and drink because it can't properly pass into the stomach. And so we call this megaesophagus. And you can imagine how uncomfortable that would be for patients. So achalasia occurs when the lower sphincter won't relax and the esophagus peristalsis slows down, and then we have a dilated esophagus as a result. Let's talk about diverticula. Now, a diverticula is an outpouching. It's a pouch pointing outward from the organ. And these can occur anywhere in the digestive tract. Here we'll talk about esophageal diverticula. But again, they're outpouchings from the wall of the organ. Now, stomach diverticula are generally 1 to 2 centimeters, so they're relatively small, but they can grow as large as 8 centimeters in diameter. And you see a pretty big one right here, this outpouching. So this is outside of the stomach, okay? And of stomach diverticula, 70 to 90% of them occur in the posterior aspect of the fundus. And that's why that right lateral is so important during an upper GI study, because that might be the only projection that shows us that diverticula. Most stomach diverticula are asymptomatic, meaning the patient displays no symptoms, and they're actually discovered by accident. So again, this is an outpouching of the stomach, and you can see how contents from the stomach do get trapped in there. Zenker's is an example of an esophageal diverticulum. So diverticulum being singular, diverticula being plural. So with Zenker's, you have a large outpouching of the esophagus more proximally, generally. And they believe it's caused by a weakening of the esophageal wall. Because of the large size of this diverticulum, the patient's going to experience dysphagia. They may aspirate food or fluids into their lungs. They may regurgitate food that they ate hours earlier that has become trapped in the diverticulum. Medication can help reduce the symptoms of diverticulum, such as dysphagia, but really most of the time these patients need surgery to correct that outpouching. And you can see here, this is the lateral. So this is a large outpouching from the esophagus, and then here are the AP projections, and you can see barium has been trapped in this pouch. It's like a little purse hanging off of your esophagus. All right, let's talk about Barrett's esophagus. Now, in Barrett's esophagus, normal tissue in the distal esophagus is replaced with tissue from the stomach. And this is concerning because it can be precancerous. So patients with Barrett's esophagus are monitored generally yearly or every few years to make sure that that tissue isn't becoming cancerous. People at a higher risk for Barrett's esophagus are those people who have long-term reflux. So GERD, gastroesophageal reflux disease, where you constantly have gastric juices refluxing into the esophagus, those patients are at a higher risk for developing Barrett's. So the normal tissue of the distal esophagus is replaced by tissue that normally lives in the stomach. And we are concerned about that because it can increase the risk in developing esophageal cancer. All right. Let's talk about carcinoma of the esophagus, and as you know, carcinoma means a malignant tumor. And oftentimes these are caused by smoking, tobacco, alcohol use, diet. Remember Barrett's esophagus. And what it does, a carcinoma of the esophagus is a tumor, and it's going to cause a narrowing of the esophagus. So here's a great example. A lumen, right, is the hole or the opening in the esophagus. So any tube, like even the large intestine, the inside where all the contents pass is called the lumen. And you can see how the lumen is becoming narrowed because of this large tumor. Okay. Now, adenocarcinoma is the most common esophageal cancer, and it usually affects the distal part of the esophagus, and interestingly, it primarily affects white men. Now, advanced symptoms, so symptoms when the disease process has become advanced, include difficulty swallowing or dysphagia, pain while swallowing, and even bleeding. Other types of malignancies in the esophagus include carcinosarcoma, and that often produces a large polyp. And we'll talk about polyps more later, but a polyp is the opposite of a diverticula. A diverticula points out, a polyp points inward towards the lumen. And we'll talk about that more later. But the point being that a cancer of the esophagus can cause a large polyp as well. Here's an example of carcinoma of the esophagus. Obviously, the white is the barium, and you can see this right here is a large tumor, and it is restricting or growing into the lumen, and so it's narrowing the esophagus. And you can imagine how these patients would have difficulty swallowing. All right, let's talk about a fistula. So a fistula is an abnormal passageway, and this occurs, you can be born with this, it can be congenital, or it can occur from a buildup of scar tissue. Fistulas can occur anywhere in the body, so it's just a hole where there shouldn't be one. But if you look at the diagram here, it's a hole that connects two organs. So this would be your trachea on the left and your esophagus on the right. And you can see why this is so concerning, because food and liquid can pass into the trachea through the fistula. And of course, we're concerned about that for aspiration. Now, if we look at the next slide, atresia, this often occurs with a fistula. I shouldn't say often. Fistulas and atresia can occur together. Scratch the word often. Esophageal atresia is a congenital condition, meaning you're born with it. It's a birth defect, and it affects the alimentary canal. It causes the esophagus to end in a blind pouch rather than connecting normally to the stomach. So you can see here, this little baby, they've given the baby barium, and it just stops. This is just an ending, a blind pouch. It's not connected to the stomach as it should be. So obviously these patients are going to need surgical repair to connect the esophagus with the stomach. So atresia is no opening. All right, let's talk about varices. Now when I say varices, I am referring to varicose veins. And varicose veins can occur anywhere in the body, but here we're going to talk about esophageal varices. And a varicose vein is very simply a dilated vein. And oftentimes we see esophageal varicose veins or varices in people with liver disease. Think about patients that maybe have cirrhosis or a diseased liver. They're going to have restricted blood flow in that liver. As a result, the veins around the liver in the other organs become dilated and engorged. And that's what leads to this pooling or this varicose vein. So generally, again, people with esophageal varices or varicose veins in their esophagus, that's as a result of some other disease process causing restricted blood flow. And again, oftentimes in the liver. Okay, here's an example of varices of the esophagus. So you can see all the black areas are going to be the varicose veins, and they kind of cause a narrowing in the lumen of the esophagus and what's called a cobblestone appearance. All right, let's talk about a few disorders of the stomach. Let's talk about a hernia. So we've talked about hernias before in lab, but I want to talk to you about a Schatzki's ring. So this is a sliding hiatal hernia. And what we mean by that is the presence of the hernia can improve or worsen from time to time. It moves. So what happens is the esophageal sphincter is weakened in these patients, and the part of the stomach below the diaphragm can sneak up the opening of the diaphragm where the esophagus normally lives. So let me say that one more time. there is a hole in the diaphragm to allow the esophagus to pass into the stomach, right? Sometimes that sphincter between the esophagus and the stomach can weaken, and that can allow part of the stomach to slide through that opening in the diaphragm and up over the esophagus. And that's what we see here. This is part of the stomach sliding up over the esophagus. Okay? Now again, the degree of herniation can vary from time to time, and that's why we call it a sliding hernia. This condition is often present at birth, but symptoms such as difficulty of swallowing or dysphagia often don't present until young adulthood. Okay, so again, part of the stomach is sliding up through the hole in the diaphragm where the esophagus normally passes, and it's covering the esophagus, and it can slide back and forth from time to time. So we call this a Schatzki's ring because you have this ring-like appearance where the sphincter is present. All right, here's an example of a lateral chest with a hiatal hernia. And we've seen hernias in lab. Again, the stomach is poking up through the hole in the diaphragm where the esophagus normally passes. And in this case, it's not a sliding hernia. The stomach is extremely protruding into the thoracic cavity. So this gas bubble right here is your stomach. So they're going to push that stomach back down through the hole in the diaphragm and repair that muscle. All right, bezoars, one of my favorite pathologies. A bezoar is a mass of undigested material that becomes trapped in the stomach. Now, usually bezoars are made up of hair, vegetable fibers that are undigested, or even wood products. And the material builds up over time and it actually forms an obstruction. The patient cannot digest this mass. There's different kinds of bezoars. A trichobezoar is made up of hair. A phytobezoar is made up of vegetable fiber or seeds. There are some patients out there that just can't break down certain vegetable fibers, and it just becomes this large mass in their stomach that they can't digest. Now, oftentimes you'll see this mass present in the stomach, and this bezoar will become coated with barium, and you know something's there. You can tell there's something there because you don't see rugae, right? Even after the esophagus, or the stomach empties rather, you can still see the bezoar coated with barium. So it's kind of interesting. And here is the stomach has been cut open to reveal that bezoar. So kind of interesting. All right, so let's talk about ulcers. We'll wrap up the upper GI pathology with ulcers. All right. An ulcer is an erosion of the stomach lining. So this can be caused by physiologic or environmental conditions. So physiologic, we think of stress. We think of excessive secretions in the stomach. Your diet can contribute to ulcers. Smoking can be a contributing factor. Recent studies have suggested that ulcers may be caused, in fact, by bacteria. And they're trying now, they're suggesting to treat them with antibiotics. If an ulcer is left untreated, it can lead to a perforated stomach, which we know is really concerning because we would never want to give that patient barium. They would have to have a water-soluble contrast. During an upper GI, the ulcer appears just as a little barium collection. The barium kind of collects on the ulcer. There's different types of ulcers. There is a peptic ulcer, there's a duodenal ulcer, there's a gastric ulcer. I'm not really concerned that you know about the specific types of ulcers, but if you want to know more about them, they're found in my notes on this PowerPoint. There's also, like I said, you can have a perforating ulcer, and that's going to create a hole or an opening in the stomach or the intestine. only about 5% of ulcers lead to perforation, which is good. But again, we are concerned about that because we don't want contents of the stomach leaking into the peritoneal cavity. All right. Here's an example of a duodenal ulcer. So in the duodenum, just a little irritated, looks unhealthy compared to the rest of the tissue, just an irritated part of the lining. And here's what I'm talking about. The barium kind of collects around the ulcer. So this is an example of a stomach ulcer. All right. Wrapping this up here, gastritis is an inflammation of the lining of the stomach. Again, this can be caused by physiologic or environmental conditions. Again, think of stress or diet. If you have acute gastritis, you're going to have severe pain and discomfort. So acute meaning it just came on, it just started. So you're going to have severe pain and discomfort. If you have chronic gastritis, meaning it's lasted a long time or you've had these symptoms for a while, it can be intermittent. So it might be good, then it might get bad again, and it can be brought on by changes in your diet or stress again or other factors. Gastritis is best demonstrated with a double contrast upper GI, which you can see here. So we can see air is in the stomach, so they've ingested the crystals, and then what the doctors look for is any inflammation of the lining. All right. Let me just look at my notes here, make sure I got everything. Okay. All right, stomach cancer. Finally, here you can, we talked about this a little bit in lab. Remember, Japan has a really high incidence of stomach cancer, and they believe it's due to their diet. But stomach cancer is going to have a malignant lesion in the stomach, usually occurs in the greater curvature area. So here is your lesser curvature, here's your greater curvature, remember. And so you can see where barium is not filling, that's a huge tumor. So that's really concerning. As I said, oftentimes these are caused by dietary habits such as eating a lot of pickled foods. That's what they're finding in Japanese culture. And really, unfortunately, we don't experience symptoms until often late in the disease process. And the first symptom is often stomach pain. All right, that wraps up our upper GI pathology. The next PowerPoint will include lower GI. Thank you very much.